public. So if you do you want to put your screen now, or we start? If you...
Yeah. Yes.
Well, it's now 5 o'clock in Lisbon, 6 in Barcelona. Welcome, everyone. It's a pleasure to be with everyone, and the number is increasing, which is really interesting. And thank you, Alejandro, and thank you, Humberto, for being with us today. In these NeuroTalks, that is initiative that is growing, and I'm very happy with that, and I hope it will continue like that. Let me introduce everyone to Alejandro and Humberto. They are both from Valdebrón Hospital in Barcelona. Alejandro is the head of the department, Alejandro Tomasello, and Humberto Diaz is a fellow in the hospital, and they are here today to talk and to discuss with us a little bit of these difficult cases of stroke, and specifically dissections. So thank you so much, you both, for being with us today, and thank you.
Thank you, Diego, for the invitation. I really appreciate it, and hello, everyone. I hope all are fine. As you know, we will go over some slides about the dissection. As you know, almost 20% of the tandem lesion are dissections. And as you know, probably, you know, the patient who have a dissection are younger if you compare with the patient with an atherosclerotic lesion. And when we analyze the papers published in this topic, you will see the 5 big trials, also Hermes. They not represent very well all this group of patients. You know, there is another group, Titan group. They published some conclusion regarding the patient with tandem lesion. They analyzed, they collected data from 18 institutes, I think so. And one of the conclusion is the dissection by itself should not be a contraindication for the endovascular treatment. Of course, this is obviously, but when we talk about what we have to do with the lesion, with the dissection, there are not consensus. Okay, something important to take in account is that the outcome of the patient with dissection are quite better compared with the atherosclerotic patient. Probably it's because they are younger patients with less comorbidity, but this is something important to take in mind. Okay, the idea of this presentation is we will talk about the dissection in the stroke treatment, especially the tricky case. Of course, sometimes you treat dissection in a straight vessel, but this is not the point. Okay, the point is how we manage, or we really like to share our approach regarding these tricky cases. And the reason of this approach is because when we started to work, we have very bad outcomes in young patients. And in all the cases was because of the second embolism. Always we go first to the intracanal occlusion, we open the artery, and then we work over the dissection. And when we started, and this step, when we work in the carotid artery, we have had to face a lot of embolism, okay? And this is why we start to work with this approach, okay? We really believe in tandem lesion. We try to treat the patient with stent, not in all the cases, but almost all the cases. Of course, it's important, the aspect, but and especially in dissected patient, we believe it's a good idea to keep open the artery, because, you know, it's in acute occlusion and the patient don't have enough time to form the collaterals. Okay, let's start with 2 cases. He's Humberto, and he will present these 2 cases. Okay.
Hi, everyone. In this opportunity, I'm really glad to share with you all our experience of dissection cases on ischemic stroke. We have the opportunity to share with you all also the information that we have treated among 15 patients with a flow diverter stent in case of ischemic stroke with just one occlusion of them in the control imaging. So this is a very good news because it opens the opportunity to using new strategies to treat this particular situation. So this is gonna be the experience of our neurointerventional department. Okay, so this is a male patient with a young male patient with a good aspect score suffering by a left total anterior circulation due to intercranial artery C2, C3 segment dissection. And the first thing that we saw in this situation is what about those scores? It was our first impression with this dissection that compromises the petrosus segments of the ICA. So using a Phenom 27 and a Synchro 2, we crossed the lesion and using the aspiration to help us to get distal to the intracranial circulation and check that everything was okay over there. Or see that there was a clot inside to perform the thrombectomy. And just as a recommendation, use the intermediate catheter with aspiration to get the intracranial circulation if you are using it. Dual antiplatelet therapy was indicated, and we wait among 10 or 15 minutes to make them effect. And posteriorly, we perform the liberation or the release of the follow diverter, and do a dispatchability to be deployed in case of informal anatomy is a very good option to be used to treat those cases. It's normal to lose your road after the stent release, but recovering is not a big deal using a flow diverter stent, because although it was after being released, it's not completely open, you can navigate inside of it using your microcatheter. So because of their characteristic, it's very easy to get back to the road that it was missing after deploying the stent. And remember, the self-expanding nature of the flow diverter reduces the risk for thromboembolism in the first scaffolding. It means that you remember the dissection have a very high effect on thrombogenic, and using the flow diverter to contain the clot with the first scaffolding, we reduce those effects. And using remodeling balloons in this case, and after liberation of the flow diverter, we use a Sector XC and Eclipse, but we can use whatever you want, compliance balloons. The easy navigability inside the flow diverter makes it easy to do in post-dilatation after the release of the stents. So this was the last run with no intracranial hemorrhage in the CT angio control and the CT control, and with an NIH MRS of 2. So it was a very good apposition of the flow diverter without hemorrhagic complication of the CT scan. The second situation that we can be facing is crossing the true lumen. It can be very tricky when you're not using intermediate catheter and you're just using your microcatheter. So in this situation, we have a 33 years old, previously asymptomatic with a right posterior partial anterior circulation infarct with an NIH of 11. So this is one of the cases that it was published this year from our hospital. And this is a CT scan that shows us the deep right internal carotid territory infarcts in the internal capsule and the lenticular nucleus. And that shows us in the CT angio that double lumen sign that make us think of a dissection. This is a mass substrate volume rendering reconstruction that shows us what I was talking about, and also a really stenotic portion of C1 of the internal carotid artery. After the patient was taken into interventional radiology suite to be treated, we confirmed the disease, and the section it was showing up. So in this case, we were not using intermediate catheter. So my boss, Dr. Tomasello, suggests that using the balloon, remodeling balloon, can be useful to facilitate bypassing of the critical stenosis with the microcatheter. So After positioning neuromax and step-thorax C, we use it to just to push the microcatheter inside the true lumen and to navigate inside the brain. So it could be very helpful if you're not using intermediate catheter at that moment. So this was called a jacking maneuver. So the balloon guide catheter is serving as a leakage to orient the tip of the microcatheter toward the true lumen. So this is a very helpful trick to take into consideration. In this shot, we can see the successful deployment of the derivative flow diverter stent into the clinoid ophthalmic segment of the ICA. So this shows that the stent was purposely and partially deployed to the clinoid segment that was dissected. And be sure that the length of your intermediate catheter, be aware of this, because just avoid the issue navigating and releasing the flow diverter. And it was the last run, showing that it was a very nice patency of the lumen. And just to take it into consideration that the diameter of the vessel could be diminished to a thrombogenic material trapped in the stent and to the wall vessel. So don't be focused on the diameter of the vessel after being angioplasty or releasing flow diverter stent. Just be aware of the patency of the lumen.
Okay, I will try to point it a little bit, the reasons because of this approach. The technical reason, in my understanding, is the flow diverter is easy to deploy. It's especially because you have to tolerate they're not fully open at the first movement when you deploy the stent. And also you have the length and size. You have big stent of 6 millimeter and 50 centimeters or millimeters of, centimeter of length. The high metallic surface, I think it's something important because you can scaffold the clot, and it's very easy to navigate through the stent despite it's not fully open. And this is a great thing. Also, there are some brands that are working in the coating on the surface, which is something important. There are several working on the same line, and probably in the future, maybe we can use only one anti-aggregation therapy. The philosophical reason behind all of that, it's make easy a tricky treatment. The first point is you have to stabilize the clot, and then you have to angioplasty the lesion. Okay, we will share with you the steps. When we use a flow, of course, when we have a long dissection with a lot of amounts of clot burden, of course, we use it also in intracranial dissection, not in all the cases. Of course, in a straight vessel in the cervical internal carotid artery is not necessary, but okay. The steps, very fast. We'll go over. The first step is the thrombectomy. You have to, of course, you have to diagnose the dissection is something important. Also, you have to cross the lesion with, in the cervical segment, especially if you have a lot of curves, it's tricky. It's not easy to do this. After that, we in our hospital, we usually perform the thrombectomy. Okay, you know, there are many dissections that happen in this kind of anatomy, and when you start the treatment, you're blind. Okay, especially in our hospital, we move 1/3 of the patient or more direct from the ambulance to the angio suite without a CTA. And if you face this kind of patient, it's tricky. Okay. Of course, we can talk after, if you like, about how we cross the lesion, and we perform the thrombectomy. And after that, if we achieve the thrombectomy, we start with the antiplatelet therapy. Something important is wait long enough to the effect. We wait 10 minutes or something like that. Then we perform the stenting, okay? We usually in these cases, we use a 125 centimeters navian, not so long. And when we perform the thrombectomy, after that, we change the micro inside the intermediate catheter, and we place the stent, okay? The idea is to make the scaffolding and the clot stabilization. You have to tolerate the not complete expansion. Yes, it's obviously because the dissections have clot and the stent, they don't have enough radial force. You have to go fast, of course, because you leave the stent without, in some part, it's not completely open or it's occluded. And you have to prepare before the deployment your balloons. We usually use balloon of remodeling balloons, but sometimes we have to use also a no compliant balloon for the angioplasty. This is, for example, a dissection. We cross the dissection with the micro and we place the stent. You can see here, it's not completely open. You can see also here. Here is almost occluded. Something important is you have to be sure that you don't have a complete twist. Okay, this is important. You have to move the C-arm in order to be sure there is a not complete twist, but you can tolerate a semi-twist. Okay. The second step is when you deploy the stent, then you go with your balloon. It's easy to navigate through the inside the flow diverter. This is not an issue. And then you have to practice the angioplasty in order to get enough space, enough size to open the stent. We really don't really like to achieve the total diameter. I think it's not necessary. And if you have a good flow, you can wait, and after a couple of months, you can finish your work, okay? And this is the remodeling balloon passing through. You can see here the Petrus segment. You can see the cloth behind the stent, okay? And you can see it's not fully open, but the important point in my understanding is you have to have a good flow, okay? And not be so aggressive against the vessel wall because there are a lot of cloth and you are really like to avoid the embolization, okay? We perform aspiration when in two different steps. When we go to the thrombectomy, at the first step, we aspirate when we go up with the distal aspiration catheter, and also when we start to open the flow diverter. You can see here we open the we open the distal part of the flow diverter here, okay, and we stop to the deployment and we perform an aspiration with the catheter. Of course, you have inside the micro, but we try to clean up a little bit the artery, okay? Tiago, are you listening to me?
Yeah, I'm here.
We have two more cases. If you
yes.
like, we can share. We go.
Of course, I was just wondering if we can just discuss a little bit now, or you prefer to go on the case and we discuss everything at the end.
We continue.
We continue. Okay.
Okay. Thank you.
Okay, so thanks to Dr. Tomasello to explain some tips and tricks on these cases. I'm going to continue to show in two more cases about two situations, especially with tandem lesion and with a continuous stenosis in internal carotid artery from intracranial to extracranial. So this one is dealing with a tandem lesion by dissection. This is a male, 47 years old, with a left total anterior circulation with suspicious of MCA, M2 left occlusion. There was the CT with aspect 7. The CT angio showed us the double lumen sign, so it confirms the dissection and also a pencil shape of the internal carotid artery in the sagittal reconstruction. The CT perfusion shows us a mismatch from the frontoparietal and left temporal with increase of the values of the TTP and TTN associated with a low CVF with preservation of the CV. So this is what the first round that confirms the dissection and show us the proximal vasospasm that was treated with calcium channel blockers. So we are aware that the last study suggests a major number of cases to treat head first, but high degrees curves like this make us think maybe to change our way of thinking about, in some specific cases, to treat patients. So in this case, we decided to stabilize the thrombogenic effect of the dissection at first and make easy to navigate to those course on unfavorable anatomy to make the thrombectomy on the internal ICA. So this was a video that shows us the liberation of the flow diverter that's in some corners was partially deployed, but navigating with the microcatheter inside of them, we can be able to open it completely. After the stent deployment, we need to get everything ready to perform the angioplasty. So remember, time is brain. Be gentle with the artery, that will not be to be so aggressive. We can allow us to not to recover the whole diameter of the artery. The aspiration was made proximal to distal to position the distal intermediate catheter and made to thrombectomy with a clutch engagement between the stent trigger and the aspiration catheter. So with a reverberation for a stent trigger and aspiration technique was performed to make the thrombectomy with a final result of TC2C with no hemorrhagic complication. And this is my 4 case to share with you all. This is a multiple stenting for reconstructing a pathway. A young male with headache with brachial palsy on left hypoxians and right partial anterior circulation infarct as 10 aspect. And the CTA show a sharp occlusion of the right ICA C1 to M1. And this is the first run-up that confirms that we were dealing with a sharp occlusion of the right ICA, but nothing else can be seen. Sometimes the road is blind. So after navigation through the blind road and getting sure that everything was okay inside the brain, we need to come back to solve the problem. So the left ICA gave a bad collateral to the float to the contralateral hemisphere. So the wire was, the wire show us the truth. So this was a complex anatomy of the artery. So what about now? We use a pipeline flow diverter to protect the thrombogenic effect of the dissection on a high degree cold ICA, and then the liberation and gentle angioplasty pathway recovered with the microcatheter and the wire, and then the liberation of 2 more stents. Neuroformal wall stent was used to reconstruct the whole road to the proximal part of the internal artery. This is overlapping of the stents in the reconstruction. We saved the lumen in just the patency of the lumen with no internal occlusion of the cerebral arteries in this last series. So this is a way to invite you all to participate with us. We are now recruiting patients for a flow diverter reconstruction for intracranial carotid artery dissections during thrombectomy for acute ischemic strokes. So if one of you all have cases with treated with dissection, treated with flow diverters, don't hesitate to contact us. Those as our emails. So send us that you are agree, and we can send you back the serial to collect all the information. I'm gonna give you the chance to finish the lecture to Dr. Tomasello, and thank you all for listening.
Thank you, Humberto.
Okay, Diego, we are ready.
Well, we have 2 questions already. I have a couple of more as well, but if anyone wants to share your questions, please, I'm very happy to give you video and audio for doing that. Well, I think we have someone already. Oh no. But we have 2 questions. So one of the questions is Dr. Kumar asking what stent is preferred for long segment dissections involving petrocervical segment in the acute setting. So which stent for long dissections would you prefer? I'm assuming that probably Dr. Kumar is asking if you don't want to telescope flow diverter.
It's an option. It's of course it's an option, but for the moment, most of our cases we are using the Derivo, and especially in the cervical part of the base skull, we use the 650.
The 650. Okay, yeah. So that's what was another question. That was the size. So I think one of the other questions is what are the main advantages of flow diverter instead of neuroform, for instance, or open?
Yeah, the concept is I understand. The concept is you usually when you work, you usually perform the angioplasty and then you place the stent. Okay, this is the almost all the cases we do this, but in this case you change because you are concerned of the embolism. What you are looking for with your flow diverter is, or with your stent, is to scaffold the clot, to protect the clot and to stabilize. And after that, you come back with your micro, with your balloon, whatever, and you perform the angioplasty, and you get the diameter that you are looking, or what you are looking for. The point is, the old stent that it's so easy to navigate through, especially when it's not or fully open, it's the flow diverter. And this is the different compared with our first case. Now we place the stent. After that, we perform the angioplasty, and we are not concerned to leave the stent. And the first maneuver, we leave the stent if not completely open and almost occluded. We leave the stent and we go fast, of course, and then with the balloon, most of the time, a remodeling balloon, we finish to opening the stent. But the point is, stabilize the clot.
Okay, which balloon are you using?
Most of the time we use remodeling balloon. I really like the Scepter XC, okay. But of course we can use Eclipse, and sometimes, of course, if we are facing some tight stenosis or hard to open, we can use NeuroSpeed or Gateway. Okay.
Well, I have here Dr. Tarek that is probably going to talk. Yes, Dr. Tarek, you can talk now. You cannot. Hello.
The micro is closed.
You are very welcome. Whenever you want, you can. Well, anyways, meanwhile, because I think Dr. Tarek needs to allow his microphone to start. I'm just wondering, one of the problems that we have when we are putting stents in the carotid for atherosclerotic lesions, and when we are under RTPA already, that's a problem for symptomatic hemorrhagic complications. So what are your concerns in these situations? Are you talking with your neurologist to avoid RTPA previously? We know that today we have that there's a paper published on that as well. So what are you doing in that situation? If you know that you are doing acute flow diversion, what are you choosing in terms of RTPA?
The TPA will still continue using probably because we are starting with this kind of approach. But I really believe soon we will not use it. Of course, the papers are, appearing, and the information it's getting hard. It's strong, and I think in the near future we will try to avoid the TPA in these cases. Something important, coming back to your first question, it's of course you have to balance the risk. If you have a patient with aspect 7 or 6, and you take 2 hours to get the recanalization, probably it's not the best approach. But when you analyze all your cases, you will see, or probably in my daily life, most of the patients are aspect 10 or 9. And in this patient, in 40 minutes, we achieve the total recanalization. What I'm trying to say is, most of your patients will have a good aspect, probably, okay? But if you have to face a patient with a bad aspect, or the mounting factor is so much, of course, I will not do it. When we analyze our data regarding the double antibiotic therapy in a tandem lesion, we'll see if we're using all the patients, we have symptomatic hemorrhage in more than 30 or 14% of our patients. Of course, it's a risk. But what I'm trying to say, if you have a young patient with a good aspect and you have a trick lesion, this is one option, not the only option, of course.
Yeah. Another question is very, very interesting. If you have a follow-up of these patients, what happened to the clot?
Sorry?
If you have a follow-up of these patients, a DSA on these patients at 3 or 6 months, what happened to the clot? What could you see? Probably not the clot, but the stent opening.
Yes, a little bit.
Yeah.
Yes, a little bit. most of the time we leave the stent not completely open, especially in the part that you have the big clot, because I think it's not a good idea to squeeze the clot, okay? But when you come back, and also if you can analyze in your CTA, you will see a little bit more better size compared with the last angio when you finish your procedure, because the clot, you know, there is an organization of the clot.
Yeah, yeah. Another question is, considering the high cost of flow diversion, what would be the alternative, low-cost alternative for flow diversion?
The point is, of course, it's expensive. But yeah. I am talking about my life. I don't know in the other hospital what happened, but in our life, if we use, because we have patients treated with regular intracranial stent in this situation, but in most of these cases, we spend a lot of money in balloons, 2 or 3 stents. Of course, a stent is 10,000 euros, but in most of those cases, we use only one flow diverter and one balloon. Supongo we have to analyze.
And also are very, very young patients usually, so it's worth it, I would say. In relation with COVID pandemic, have you had cases of stroke in younger patients associated with this disease? There has been cases associated with dissection in COVID. Well, I know that we have some COVID patients, no dissection so far, because actually I agree with the question, because at least I think it's very pertinent, because stroke patients with COVID disease probably are younger, or sometimes well, those in New York were younger. So we don't have that experience anyway.
No. Mm-hmm.
Okay. Another question from Dr. Ferrara. Are you using any stroke core volumes as a criteria for acute stenting decision?
Sorry, I missed you.
The question is if you are using the core volume to decide if you are going to stent the patient. I mean, I think the problem would be the hemorrhagic risk here.
Yeah,
you would do it anyway, I think.
Yes, I really use the CT, the plain CT, and we never rule out a patient with the CTP. We perform the CTP, we analyze, but we will really try to analyze the infarct volume, the admission infarct volume with the aspect. I think it's enough. Of course, we need more information. We have only 15 patients. We need more information, of course. But if you analyze tandem lesion, it's the same. We will talk about the same topic or subject, because we have doubts about that. This is only an option in some cases. And in my understanding, you make easy a tricky treatment. We don't have the time, but maybe in the future I will share with you the time of this procedure. It's not so much, because it's very fast. You open the stent, you perform the angioplasty.
Yeah. Regarding the jacking maneuver, how do you actually place the balloon when you are trying to?
Yeah, the point is.
How do you decide that?
No, it's difficult. It's very important, I think so, to analyze the angio. Analyze the angio and try to understand what happened. It's difficult, but it's very important to see where is the section, and you have to plan where you will try to go. Of course, you can go with your guide wire and try to find any place, but I think it's important first to analyze, and second, in the cervical segment, it's different when you compare with when you are in the skull base. In the skull base, if you have the dissection, it's more tricky to cross the lesion, because probably it's the bone, I don't know. And in this case, in the published case by Dr. Gravena, the point was we clearly see that the true lumen was in the upper part of the artery, and the O27 went directly to the lower part of the artery, and I thought maybe I can jack in the catheter and it works pretty good. But this maneuver, I think it could be useful, but especially in the basal. In the cervical segment, it's quite different.
Yeah. Several people are asking what's your antiplatelet regimen. So I know that you have the screen there. Can you share with us again that slide?
Yes, but we use Ingesprint, IV aspirin.
Okay. Yeah.
I know in several countries it's not available, but we used when we start the procedure, and when we decide to use the flow diverter, of course you need to use the double antiplatelet therapy, and because it's a long stent, there are clots. It's different. I know you know in some cases in aneurysm, rupture aneurysm, you can say I will put only one antiaggregation therapy, but in those cases with a lot of clot, I think it's not a good idea to use only one. We start with irofevan. In almost all the cases, we load with the charge dose, and then we continue with the normal dose. But we have two cases in which we avoid the loading dose of irofevan, and we start only with the continuous doses. Okay.
Okay. Yeah. So Alejandro, I have one question for you, probably the last one, which is, what about posterior circulation dissections? Are you doing exactly the same?
I don't know. I don't know. I really, because the dissection that we have to treat in posterior circulation now, I am not sure, but most are in the vertebral arteries, and it's different because in those cases probably it's easy to stand, or I don't have experience on that case.
Okay.
With flow diverter, I said.
Yeah. Well, we have some Dr. Shariat. That please, you are online. You can ask a question if you can hear us. Wow.
I can't.
Can you hear? I can't. Wow. Zoom is not as good as we think. Well, Alejandro and Humberto, thank you so much. It was really a pleasure to have you here today in these NeuroTalks. It started as a small group. Now we are a nice group. So I think I need to ask someone to do my job as well. Yeah. But so it's really interesting. Oh, someone sorry again. Yeah. Hello? No.
The micro is off. Both have the micro. Yeah. You can open the micro of them. Switch on the micro of them.
Me? Okay.
Yes, you can. No, this is your micro.
I know, but I can't do that. Okay. Now we have Dr. Afalai. Hello? No. Okay. Alejandro, thank you so much. And next week we have another episode with Dr. Luisa Biscoito. She's also Portuguese. Well, I'm Portuguese. You are both Spanish, but she's a Portuguese interventional radiologist. She was president of CILAN as well, and she's really good interventional radiologist. So I invite you all to be here with us next week, and we are talking about ophthalmic approach for carotid cavernous fistula. So I think, and she has really nice pictures and movies that she will be sharing with us. So I think it will be a nice neuro talk as well. So thank you so much, and have a nice weekend.
Okay, bye-bye. Thank you for the invitation. Bye-bye.
See you next week. Bye-bye.